Well, good morning or good afternoon, depending on which time zone you're meeting us from. Today, we're going to be talking about the use of long-acting buprenorphine, learning from the NIH Innovation Study. My name is Janet Young. I'm a program committee member, and I'll be your moderator today. So without further ado, let's go ahead and let Catherine Hawk bring us in.
Perfect. Thanks so much, Janet. My name is Catherine Hawk. I'm an assistant professor at the Yale Department of Emergency Medicine. And I'm here today with our large team of amazing co-authors and study investigators to talk about a new study that we're doing through the NIDA Clinical Trials Network on long-acting buprenorphine. And so with that, we're going to take it away. It's going to be a rapid 50 minutes. And we're hoping to save time for questions at the end. But over the course of the talk, if there are things that come up you want us to address, feel free to drop it in the chat box, and we'll try to make sure that we either cover it as we go through the material or get back to it at the end. So without further ado, so these are our disclosures. This work has really been funded by the NIDA Clinical Trials Network and with some involvement of support from ED Bridge. And the medication was provided by Braeburn, which is the company that manufactures CAM 2038 for study use, but they did not have any planning or funding overall for the study. So this is our study team. It is led by our PI, Gail D'Onofrio, who's professor and chair of the Yale Department of Emergency Medicine. The rest of our team and co-presenters are here. Dr. Ethan Cowan from Mount Sinai School of Medicine, Ryan McCormick from Bellevue, NYU School of Medicine, Jean Marie Perrone from the University of Pennsylvania School of Medicine, Liz Samuels at Brown, Andrew Herring at Highland Alameda. And so you'll hear from most of us over the course of the hour, and drop your questions in the question box as we move forward. So now I'm going to hand it off to Kristen Huntley, who's our project officer and liaison through NIDA for this trial.
Good afternoon, everyone. As Dr. Hawk mentioned, I'm a scientific officer in the NIDA Center for the Clinical Trials Network at the National Institute on Drug Abuse. Next slide, please. The ED Innovation Study is funded through the NIH Helping to End Addiction Long-Term, or HEAL, initiative. This is a trans-agency effort to speed solutions to address the opioid overdose public health crisis. $500 million a year in research funding is supporting hundreds of projects across the NIH, which are focused on understanding, managing, and treating pain, and improving treatment for opioid misuse and addiction. Next slide, please. The research in ED innovation is being conducted through the NIDA Clinical Trials Network. And there are also some siren sites participating in the project. The NIDA CTN is a network of 16 nodes or main sites, which have numerous affiliated sites, such as primary care practices, emergency departments, and specialty addiction treatment centers affiliated with them. The CTN, or the Clinical Trials Network, is also supported by a clinical coordinating center and a data and statistics center. Next slide, please. This slide highlights some of the resources that are available to clinicians and health systems that are interested in implementing ED-initiated buprenorphine programs. The research team has collaborated with organizations like NIDA, SAMHSA, and the American College of Emergency Physicians to develop materials and resources. The California Bridge website and the Yale website have terrific resources, and the ACEP Equal Opioid Initiative and the ACEP Pain and Addiction Care in the ED accreditation program are extraordinary opportunities to get support for quality improvement initiatives. And I'll hand the mic back to Dr. Hawk for more information about what we're learning from ED innovation.
You're on mute. So I'm Gail D'Onofrio, and I'm going to talk to you a little bit about ED innovation and where we're getting all this learning experience from that we'll present later on during the hour. So just to give you some background, ED initiated buprenorphine, as we know, with ongoing medical treatment, very effective, but there are many barriers, that including obtaining a data waiver, and even though there are new changes to that, there's still onerous requirements of applying for those data waivers. There's lack of prompt access to community providers, even more so now in the era of COVID. And patients often lack insurance or picture IDs or other types of requirements that need to be pre-authorized, so that it's more difficult for individuals to obtain that prescription and to continue on. And of course, there's often lack of transportation and just these very vulnerable populations who experience homelessness, et cetera. So this new extended release buprenorphine formulations, CAM 2038, which is marketed by Braeburn, still under IND at this point and may come out later on this year, allows us to have an induction that can be done right in the ED, and it may address many of these barriers. Go ahead, Kate. So ED innovation is a hybrid type 1 effectiveness implementation design, which means that it expands and is its main outcome is effectiveness, while also employing implementation methods as well. So we have been able to, in 30 EDs around the country, to use implementation facilitation and achieve competence in ED initiated buprenorphine sublingually in these diverse EDs, but that's great. We then had 27 EDs who have gone on now to the randomized controlled trial, which is to compare the effectiveness of the 7-day XR-bu preparation and our traditional sublingual preparation induction in approximately 2,000 patients with untreated OUD that present to emergency department with the primary outcome of engagement in formal addiction treatment at 7 days. Go ahead. We have some additional aims that are really exciting that we'll talk about probably more in the future, but we had an ancillary aim in that since many patients are not withdrawing enough to start the sublingual induction, our ancillary aim that we conducted in 4 sites was to assess the changes in opiate withdrawal signs and symptoms over a 4-hour period among patients who had low CAL scores. So they were less than 8, and could we in fact initiate this injection at that time? And we're also, under the leadership of Dr. Andrew Taylor, developing and validating an EHR opiate-related phenotypes to more accurately characterize key presentations. Go ahead, Kate. So this is our team. You've seen many of them also who are going to be presenting today, but it is a large team, or not just from Yale, but down in New York City, and Dr. Prone at Penn, and we have our expert consultants, Dr. Loftwell and Dr. Walsh from University of Kentucky. Go ahead. So we're going to talk a little bit about this trial that we're going to talk about in our cases. Go ahead, Kate. So there are 27 sites. These sites are relatively diverse all over the US. They do involve some community sites as well as academic sites, smaller sites and large sites. And we have about 8 that are west of the Mississippi and the rest are east. Go ahead, Kate. And we'll be, Dr. Cowan will be telling you more about the pharmacokinetics of CAM 2038, but essentially we're using a 24 milligram dose, which is equivalent to 60 milligrams of sublingual buprenorphine. It's an injectable, it's easy to do, it's a tiny needle. Go ahead. And our eligibility were 18 years or older that obviously had moderate to severe opiate use disorder, who were not in treatment in the last 2 weeks, because we're not trying to steal people from places that they're already going. These are untreated individuals. They had to have an opiate withdrawal scale of greater than or equal to 8, and they had to test positively for point of care testing for opiates, which could be any of the following that are there, and they had to speak English sufficiently to understand the procedures. Go ahead, Kate. And our only exclusions really are that the patient was not positive for methadone, they were not pregnant, because with pregnancy, we just put them right into a regular path, and that they didn't require hospitalization and they weren't actively suicidal, or that they couldn't require opiates for pain as well. And go ahead, Kate. So right now, we have 350 patients who are enrolled in the RCT. In those 27 sites, it's about 25% expected, but we've also gained lots of experience. So half of those, one would assume that half of those are the XR-bup, and so we have a lot of things to tell you. Go ahead, Kate. And in the ancillary study, just to tease you quite a bit, go ahead, Kate, is that we actually were looking at these low-cal scores because of what you'll find out about the pharmacokinetics. It's a slower rise. And so could we in fact inject individuals that had these low-cal scores? Would they transition to moderate or experience precipitated withdrawal? And so we've completed that. Go ahead, Kate. We've completed that trial in 4 places that people were massively experienced with any type of injection, and we're able to treat any complications. I can tell you that we have 75 patients have now been enrolled, and they have done quite well, and we will be expanding. Just heard that this second, Dr. Huntley, we will be expanding our RCT to go less in this so that we can do home induction or unobserved patient induction for sublingual, and we can use the injection. So go ahead. So I'm going to now pass this on to Dr. Cowan from Mount Sinai, Beth Israel, and he will talk to you more about the formulations and how that works.
Great. Thanks, Dr. D'Onofrio. Kate, next slide, please. Okay, so I'm going to spend about 5 minutes really talking about the pharmacokinetics of the CAM product. So for the purposes of this discussion, I'm going to assume that everyone attending the didactic today, like our team before this study started, really never had experience with the CAM product. Now, the CAM product comes as a weekly or a monthly preparation at different doses. So on this table, what you see is how each injectable dose is roughly equivalent to a specific daily sublingual dose of buprenorphine. So as Dr. D'Onofrio said, in ED Innovations, what we're using is a 24 milligram weekly injection, which is the equivalent of about 12 to 16 milligrams of daily sublingual buprenorphine. In terms of the pharmacology of the CAM product, there's nothing new here. CAM is buprenorphine and buprenorphine is CAM. So it's very important to remember that it's not a new drug, it's just a new mechanism of delivery and a new formulation of buprenorphine. Same method of action as sublingual buprenorphine. What's different again is the product formulation. So after injecting the product into the subcutaneous tissue, it becomes this gel-like crystal. And actually that's why we don't want patients to rub the site after they get the injection. And that crystal basically dissolves slowly over time. And that's how you get this prolonged period of release of buprenorphine. So next slide, Kate. Okay, so I just told you that the pharmacology of the CAM product is identical to the sublingual buprenorphine, but what differs between sublingual and CAM is really the pharmacokinetics. And the left-hand picture here tells you, I think, the whole story of what you need to know. On the x-axis, you have the time in hours, and the y-axis, you've got the plasma bup concentration. The light gray line here is the sublingual bup, and the dark black line is the 24 milligram CAM product that we're using in our study. So with sublingual bup, what you see is a rapid rise in plasma bup concentration after a single sublingual dose, and the peak levels reached in about 1 to 2 hours. So that's that really sharp incline on the light gray line. Then you see a rapid decline and a long tail. What you see with the CAM product is a little bit different. So you also see a rapid increase in plasma bup concentration, not as rapid, obviously, as the sublingual, that reaches peak concentration around 24 hours, and then you've got a long, slow decline over the next 7 days. The two important takeaways here are that the CAM product is not slow onset. It's obviously slower than sublingual, but it's not slow. It achieves equivalent plasma concentrations of bup to sublingual at about 4 hours. The second thing to note here is that the tail, or the time that the product produces measurable plasma concentrations of bup is quite long. So what I would say here is that once you're on the train, you're going to be on the train for about a week. So the bup is going to stay in the system for about 7 days. This is shown graphically more in the diagram on the right-hand side. And the one thing that I would point out here on the right-hand diagram, as well as the one on the left, is that the standard deviations of bup concentrations in the plasma is quite wide, whether we're talking about CAM or sublingual bup. And what this is telling us is that there's a lot of individual variability in the concentrations that are reached in the plasma in different patients. Next slide. So what I've been showing really is the pharmacokinetics of the product, not how it's actually experienced by those who are using it. So this slide shows the clinical trial data that led to the FDA approval of CAM in the United States. And again, it hasn't been released yet, but it is approved. So here, the diagram that's shown is the non-inferiority randomized controlled trial conducted by two of our study experts, Dr. Loeffel and Walsh. In this study, one group received standard sublingual buprenorphine and the other group received the CAM product. And what the FDA was most interested in for licensing was the number of negative urines at 8 pre-specified time points over a 9 to 24-week study period. There was a second primary outcome, which was more of interest to the European Medicines Agency. And again, the idea was to get this license also in the EU. So the EU is more interested in what was called the cumulative distribution function for no illicit opioid use, which basically in its simplest form is just the number of negative urines for the entire course of the study. So next slide. Okay. So for the primary outcome, the CAM product was shown to be non-inferior to sublingual bup. And you could also see here on the bottom that the mean percentage of opioid negative urines over the course of the study strongly favored the CAM product, 35.1 to 28.4. So both of the primary endpoints showed non-inferiority to sublingual buprenorphine. Next slide. So next slide, Kate. So these outcomes may be of a little bit more interest to people on this call. There was a number of secondary outcomes that were evaluated as part of this study, all of which again, were shown to be non-inferior to sublingual bup, and that included retention in medication treatment. So that's the top diagram, opioid cravings, which is shown in the middle box on the bottom, and then the COW scores, which is shown on the most right diagram on the bottom. I'd also add that a study actually was published just last week in JAMA Open by a group from Australia that looked at patient satisfaction with the CAM product compared to sublingual, and that group found that satisfaction was significantly higher in the long-acting injectable arm of the study. So not only is it not inferior to sublingual buprenorphine, but it does appear to be quite satisfactory to patients who are getting the product. So with that, I'm going to hand it back to Kate or Jean Marie to actually start to talk about some of the cases that we've had in ED innovations with this product.
Yeah, hi everyone. My name is Jean Marie Perrone, and I'm an emergency physician professor at the University of Pennsylvania, and I run an ED buprenorphine program. So I was excited to join this study because, like many of you, we were trying to get more people into care. And this is an experience that we had in the ancillary arm, which was patients who were asked to enroll in the injectable formulation of CAM 2038. So this was a young couple who came to us seeking treatment, actually referred to us because they had gone to the syringe exchange program, which was allegedly a place where they could get started on buprenorphine. However, they were unable to take new patients at that center, and so they referred them to our emergency department. The patients described an escalating use of what they thought was oxycodone pills that they were buying from a colleague over the course of a year, and their use had escalated to 5 or 6 pills a day, which was costing them a lot of money, and they could no longer afford that. They had a 3-year-old daughter in their care. Next slide, please. What we found in our area, and probably in many areas, a lot of the street oxy contains fentanyl or contains only fentanyl. In this case, the patient's urine revealed that it was positive for opiates and fentanyl, so a mixture of either morphine, codeine, or other products and fentanyl. So the patients both had mild withdrawal symptoms, and this was in the arm where patients could be enrolled with a COWS of 4 to 8. So they both presented with mild symptoms and both got their injection. You can see that incrementally we measured COWS scores every 30 minutes in this arm of the study. And you can see that each had some response and mitigation of symptoms, but each had their own slightly individual variability in response. Next slide. Both patients did really great. They were super appreciative. They had so much angst and anxiety about concerns that their withdrawal symptoms would escalate or would not be treated adequately with the injection. And so they gave us lots of feedback as part of the study. They answer survey questions every day. And so in response to the study phone, they sent us some positive feedback. They were referred to our primary care doctors, and one of the patients is still enrolled in care and still walks by the ER to say hi to us. So it's been really gratifying to see her incredible success. I think Liz is up next.
Hi, everyone. My name is Liz Samuels. I'm an emergency physician at Brown, and I am one of the site PIs for the randomized controlled trial and a site for the ancillary study. So this is a case we had actually in the randomized controlled trial. It was a 36-year-old male who presented to the emergency department in opioid withdrawal. He had been using heroin for about 10 years, uses about 1 to 3 grams a day. He just moved to Rhode Island from out of state and wanted to stop using opioids. His last use was about a day and a half prior to his ED visit. He had remotely had some experience with methadone for about 6 months, but he had no recent methadone use. Does use edible cannabis, but no other substance use. Importantly, he is also uninsured. Next slide, please. So in his initial assessment, his COWS was significantly elevated. He was very uncomfortable. It was calculated at a 20. His urine drug screen did show opioids, including fentanyl, which is not surprising given the presence of fentanyl in the heroin supply. He got the CAM injection, and about an hour afterwards, his COWS had gone down to about 15, but he was still pretty uncomfortable. So he got an additional 4 milligrams of Suboxone or buprenorphine naloxone sublingual, as well as some Toradol for body aches. He was quite nauseous and wasn't really taking anything by mouth, and some Zofran. He, in about the 30 minutes, still after the additional dose of buprenorphine, he experienced some continued GI upset. He unfortunately had some diarrhea, which I think was very alarming to everyone, including him. But then he started to feel better. He did get some ancillary medications, but and the PA who was primarily taking care of this patient and the research assistant, I think the CAM for this individual just needed a little bit of more time because then he came down nicely. His COWS went down to a 7. He's discharged home feeling much better and actually picked up by his mom. Next slide, please. In his follow-up, he had saw a counselor, saw an outpatient buprenorphine provider within the 7 days after his ED visit, and he reported feeling really great, that he was more focused, doing what he needed to do. He had no desire to use the opioids or had no other opioid use. He did have some continued marijuana use, but in terms from a cravings and withdrawal perspective and treatment of his opioid use disorder, the CAM really met his needs very well. I think as Dr. Cohen was mentioning in the beginning, patients respond pretty differently. He needed, I think, a little bit more time for the injectable to start to treat his withdrawal symptoms in the emergency department. I think Dr. Herring is next from Highland.
Great. Hello. So again, my name is Andrew Herring. I'm an emergency physician, and I also run our outpatient bridge clinic. And I'm really fortunate to be part of this incredible ED innovation team. This is a case that we had here, where this is a gentleman who uses fentanyl and crystal methamphetamine, which is quite common out here on the West Coast. He was in his 30s. He's been doing this for quite a while. He progressed from heroin to fentanyl. It just in the last 5 years, he uses 3 to 5 times per day and has tried to start buprenorphine from the ED on previous occasions in the past. He never had anything bad go on during the ED stay, but it just never stuck. It never really worked for him. So he was coming in for another try. Next slide. So he presented in substantial withdrawal. He was physically obviously in withdrawal, but he wasn't really severe. He was then that kind of middle, clearly ready for buprenorphine, which with a COWS of 13 is tacky, sweaty, runny nose, but holding it together. His urine was positive, consistent with the report, with fentanyl and methamphetamine. He He received the CAM injection and started to feel better. It wasn't, dramatic, but he started to feel better. And then at about an hour, he started to feel worse. And by 90 minutes, he just suddenly felt kind of terrible. At that point, he gets another dose of buprenorphine. This time it was a 8 milligram sublingual tablet, which then made him feel much better. He then at 120 minutes receives another dose of lorazepam of 2 milligrams PO and another dose of buprenorphine. So he gets another 16 milligrams of buprenorphine. By 180 minutes, he's asleep, and by 4 hours, he's resting and then requests discharge. Next slide. So now in this new world of televisits, so he connected to us by phone on day 3. He said that after he went home, he just went home. He didn't feel great. He didn't feel bad. He just kind of felt tired and wanted to go to sleep. So he went home, he slept, and he'd been taking 8 milligrams sublingual for persistent feelings of unwell. So this mixture of craving and somatic feelings of withdrawal. So he'd been adding on top of the CAM. At day 8, he received a Sublocade 300 milligram injection, which is like the CAM, but it's just a much larger injection that then will last for anywhere from 21, 28 or more days. And at day 14, he had another visit with us and proudly mentioned to the group that this is the longest he'd gone without using fentanyl in the last 5 years, and he finally stuck with buprenorphine. So for us, this was a real example of both the power of the injectables for some of our most difficult to reach patients who have really struggled to be successful with standard therapies, that the injectable is really very, very good for this sort of chaotic pattern where you've got the motivation, but it's just really difficult for it to stick. And that the initial course might be thrown off by some difficulties, some precipitated withdrawal, for example, here, or some untreated withdrawal afterwards, but it doesn't knock them off the treatment course, particularly in those crucial 72 hours, and they're able to stick through it. So that, as Ethan mentioned, that idea of you get on the bus, and that's a really, really powerful thing for us. Next slide. I think that's where we are. So this is the talking about precipitated withdrawal. Part of it is teasing out, what is ongoing withdrawal that is insufficiently treated by whatever you're doing, and what is really this threshold event where you just from one moment to the next, you go from being at some level of wellness to being very dramatically unwell. And that is this precipitated withdrawal where you will, like as you would see with naloxone. The sort of figuring that out, depends on how rapidly and how dramatic the symptoms are. The COW score, when you disentangle it, right, gives you really all of the parameters that are going to help you figure out this fundamentally clinical judgment. So looking at the sweating, tachycardia, pupils, and all of these things. One small little thing to note is that things like clonidine will screw up your exam. And in the true blue bona fide precipitated withdrawal, might not have the potency you're looking for, but will confound your exam, particularly the pupils. So for us, what we've seen, I think, is that in general, we're really moving to a fairly simplified model where you treat precipitated withdrawal with additional buprenorphine plus or minus a benzodiazepine, and you treat it rapidly and fairly aggressively right up front, which is just sort of something that we're looking at. And with that, we have our next slide here. you could consider going big, right? And this is where we're really stepping into territory with where we need more data, we need more formal study. But clearly, when you're using the mono product, i.e., you're not using the combination product that does have naloxone in it that can accumulate, and in some people in a significant way, you can go with up to high doses, up to 32 milligrams if you need to. Ancillary medications we probably all know them, the NSAIDs, diclosamine, bentol, loperamide, ondansetron, compazine, these types of things. I really see them primarily for fairly low level events where there's a little bit of nausea, something like that. But once you have a really fulminant case, they're not going to really get you where you want to go. It's going to be primarily your buprenorphine and then something to take care of the relaxation, anxiety, and if worst case scenario is delirium. The next slide. So this is, again, the final lesson is you are emergency physicians. You are really good at taking care of people in distress. That precipitated withdrawal is something that you can really manage quite effectively, and that we are seeing it in our trial. It is rare. It is time limited and resolves with treatment, and does not knock someone off our intended treatment path, which is continuation of buprenorphine by definition necessarily. So it's something that we all should feel comfortable with as part of managing this disease. Thank you.
Thank you, Andrew. And so at this point, we wanted to make sure that we left lots of time for questions, comments. As importantly, we're still sort of mid-study, but the idea was to share some of our experience with this medication as it's going to be available on the market. And in general, I recognize the audience as one who has quite some experience with buprenorphine and may have some questions, comments, thoughts, and would really love to hear from you guys. It looks like Jennifer had a question around sort of in this population requiring additional buprenorphine on top of the injection. Are you discharging them with sublingual bup or just the CAM? And then, there's another question, follow-up question around, is there anything you're noticing about the patients need additional to rescue dosing? So I want to make one quick point before I sort of hand it off to our co-presenters to answer. And so, I think one of the things that we certainly highlighted in our presentation, but is going to be sort of different from how you may use this medication in your ED, is that we have a protocol. We sort of have a protocol for, if this happens and we do this, and if this happens and we do this. And part of that is to help us sort of get through a standardized approach to figure out how best to manage these patients. As far as, and so in general, and from that standpoint, we're not prescribing people additional home buprenorphine on top of the injection if they needed a little bit of injection to get them through the ED stay. Now, sort of whether or not that's something that people would consider in their sort of extra study practice, I think I would open it up to the group, and then see if anybody wants to touch base on that.
Like, just to kind of touch on that, if you see the difference between Andrew's case and my case, both of them needed buprenorphine in the ED, but after the ED visit, my patient reported no increased cravings, no withdrawal symptoms. They did not need any additional buprenorphine, but that was, not the experience of his patient. So, it's a little patient dependent, it seems like, although obviously we're following the protocol, but it just kind of depends on the person and their needs, I guess I would say. And one thing I would say, that's been interesting is the questions from the outpatient providers. I think Andrew has an advantage because he sees them, like he can provide the bridge care, the continued care. But it's been interesting interacting with the outpatient providers a little bit, because they're like, so when can I start them and how much, and their adjustment to an oral dose if they're not going to continue an injection. But at least the patients I've talked to who's had the injection, they want another injection. They really liked it. It's worked well for them. It's like less complicated for them, and especially when they've done so well on the CAM.
Yeah, I really agree with all of that. Particularly in the chat, I'm seeing that given that CAM requires a longer time to reach the peak. One thing, it's, I mean, it does and it doesn't, and it's quite variable in that you will experience, some people actually experience it more strongly than sublingual, and some people don't. It's who knows what that has to do. I mean, at some level, this is a physical event of placing a goo-like jelly, which is buprenorphine, in the subcutaneous fat underneath the skin. Now, the why some people end up, feeling like, whoa, they'll tell you like, well, doc, I really feel that. And other people don't, it's not really clear. So I think this principle of following the patient really holds true. For all of the buprenorphine formulations, and the CAM is no different from that.
Yeah, I think what we've seen in the study is it just shows the incredible variability of the absorption of the product. So some patients experience complications very early, like within the first 30 minutes. And then others, there definitely was delayed presentation. So they were fine for the first couple hours, and then maybe 4 hours later, they started to have symptoms. So again, there's a lot of individual variability here. And that's what you really just have to treat the patient's symptoms rather than, because the time course, I don't think is going to be that reliable.
The other thing I think we should mention to the group is we have 350 patients in the randomized control trial. So assuming that half of those got it, that's quite a few people. Plus with our ancillary study, that's 75 additional people. So we have 200, maybe over 200 and some patients who we have had experience. We have had very few problems with worsening withdrawal on one hand or precipitated withdrawal. And these are from sites all over the country, which have, as we know, patients, about 2/3 of our patients are using fentanyl. And we know that 80% really almost 85% are using some other drug in combination, but at least 2/3 of them are using fentanyl with combinations, very few straight fentanyl. So we don't have the answers to everything. People are always concerned about what happens. There's been a lot of anecdotal conversations around difficulties. We have not found this in either arm, whether it was the sublingual arm in the traditional way till they're over 8, or in the XR-bup. We have not found any significant amounts of worsening withdrawal or precipitated withdrawal. But everyone should know how to treat it. And Dr. Herring told you, because at any time you may need to do that. We just lack the understanding of why something is happening in some patients and not in others. Mm-hmm. We don't have the answer to that.
Maybe one thing that hasn't been said, and I think relates to the study, in that part of the study is there's a lot of human interaction. You're being enrolled in the study, you're explained the study, and sometimes in clinical practice, the administration of buprenorphine might happen sort of quickly, or it might even be a take-home dose where there's very little contact. So one of the advantages in the ER, where you're working individually with people, I think is that if you provide that psychological safety and you convey confidence, you convey that you're going to take care of them no matter what, you convey that small feelings of discomfort are not necessarily bad or abnormal or dangerous, that can prevent this sort of self-reinforcing, almost catastrophizing thing that can occur around withdrawal. And I think that psychological piece is actually an important intervention when you're starting people on bup.
Yeah. And another question that's come up in the chat is one around sort of the barrier of cost and prior authorization and things along those lines. Obviously, with this being a study, this is a medication that was sort of a study medication that's available. That's one of the things that we're interested in, is whether or not the ability to get people to treat effectively, lead people to treatment from the ED, whether that's cost effective. And that's one of the things that we'll look at. Anyone else want to say anything about sort of costs, or Andrew, talk about it from your perspective from using other medication, other injectable formulations?
I can add.
Go ahead, Jean Marie, please.
Perfect.
Yeah, I think, in areas that are pretty hard hit, there's been a lot of Medicaid support for medications. And one aspect that we're seeing working closely with our primary care doctors is this ability to transition patients to Sublocade. Sublocade is a long-acting buprenorphine product that lasts 30 days, and they have waived the prior authorizations needed for that in Medicaid. So I think the value of long-acting formulations is just what was presented here in terms of the pharmacokinetics. Once the patient's on that train and heading towards recovery, it's a very tricky week. We know that patients have early treatment non-adherence to sublingual bupe. They change their mind. They aren't in a safe place to start their recovery journey. But once this injection's on board, we really allow a pathway for patients to be safe and to, kind of wake up at the end of the week with, 1 week of recovery under their belt. So there's really some, I think, ultimately, effectiveness evaluations that need to be done for those kinds of transitions. But anecdotally, we've had 3 or 4 of our patients get to Sublocade from the injection, and that is just a dramatic, ability to get retention early and really give people their best trial. So, cost analysis will be important in this study.
And one other thing to clarify is that, what we're really studying is whether or not we're able to get people to treatment. It may or may not be that an ongoing injectable formulation versus a sublingual formulation, they may not necessarily stay on the injection. That's our goal as emergency clinicians, is to get people in the door to treatment. And then sort of from there, they can decide what's best for the patient based on sort of all of these other factors. It looks like, Ethan, it looks like there's a question sort of around, it's really
Yeah, I saw that.
Pharmacokinetics. And, I don't know if you just want to talk about sort of, partial agonist.
Yeah, I mean, is there an abuse potential to buprenorphine? This is buprenorphine without naloxone, right? Because obviously it's just a solo product. I mean, could you potentially do something to, well, you can't divert the product, right? Which is one of the reasons why the injectables are preferable, because you can't just give it to somebody else. In terms of manipulating the injection to increase the amount of buprenorphine release, probably you could do that. I mean, you could certainly rub it vigorously. I guess you could cut it out and do something with it. But again, I think that there's much cheaper and less invasive ways for people to abuse drugs if they want to than messing with the product. But yeah, I mean, I'm sure from a pharmacokinetic standpoint, because of the way the technology works, it does have to form this crystalline gel. And if you prevent that from happening, it's going to alter the way that the body absorbs the drug.
Yeah, but it reacts to the water content of the fat, and it forms this just tough little ball. I don't know. I don't see it. I've certainly never heard that being reported. I don't know how you're gonna. I don't know how you would do that. Like after the injection, go home and get a heating pad and a vibrator and like make it.
Yeah.
Well, and this is also not a medication that people self-administer at home. Is, I guess, the other thing that we should make very, very clear. This is, administered in a medical environment. And Gail, I'm actually flashing back to the focus groups we did with patients with opioid use disorder in the ED, where they really talk about the fact that, if I know where to get opioids. If I need opioids, I'm coming to you guys for something else. And so I think that's the right approach to think about.
They're not going to, get high on their buprenorphine, and it's going to be a protective device if they should use. And as the patients would tell you, they could go down the street and get everything that they need fairly quickly for pretty much very small amounts of money. So I don't really think that is an issue that anyone would need to do.
And that was also brought to light in a qualitative paper that Josh Lee and others did, people following incarceration, that population, that patients were not using buprenorphine to get high, but to manage their withdrawal.
There was a question in the chat about the ancillary meds, Kate. These ancillary meds are regular medications that anyone has at their disposal to use for worsening withdrawal or precipitated withdrawal. And they, you know, this can happen to anyone. It could happen to a patient who actually, an individual who perhaps used some buprenorphine on the street and came in and put themselves in precipitated withdrawal. So there's lots of opportunities to use them. While we have formulated them to be exact because we're doing a protocol, they are available at those doses that we showed for everyone to use. Nothing is study purpose is about those medications. Anyone can use them at those levels.
Yeah, and I should say that we have had patients in the study, right, that have been given, they basically came in withdrawal secondary to buprenorphine precipitated withdrawal or naloxone. So those patients are eligible for study entry.
Perfect. All right, so we're winding down to our last couple of minutes. So we have sort of a wrap-up slide that we can go through quickly, and then if you have any last burning questions, drop them in the chat. But so the overall goal that we're hoping that you take away from this, is that, so overall there may be occasional bumps in the road, but as, Andrew showed you on the last slide, all of the folks that we've enrolled and seen so far have really done well and have done well with buprenorphine and, have experienced treatment. Some of the things that we have seen is that, we have had heavy IV and those that use heavy IV fentanyl, may have had more difficult inductions, but in general, it's manageable with extra buprenorphine, as Dr. Herring sort of went through in his couple of slides. All of the patients that we saw were satisfied with, reduced cravings at follow-up. We know that worsening withdrawal can be effectively treated with sublingual buprenorphine or ancillary medications. And really the message for the folks, as was pointed out by sort of several of our folks here today, is that, once folks have the 7-day injection, they are sort of, on the bus. And so, a lot of it really is managing, patient expectations and reinforcing the fact that, this is sort of a therapeutic team relationship where, you are going to try to help them feel better, and they will feel better, if they just, stick with it, over the next, 6 or 12 hours. They will feel better tomorrow, even if they have, the first hour or two is a little bit rough. So, things that we still need to know, there's still certainly many questions. We shared a little bit of our experience, but we still have lots of questions about sort of, how to better identify people who may have more complicated inductions. And then, obviously, for many of our, patients around the country, it's not just fentanyl, it's different fentanyl analogs, it's different levels. There are many complicated factors at play. But by and large, we know that people that we've seen in the study do well with buprenorphine and do well with both formulations. And so we're looking forward to sharing with you the rest of our findings, as we enroll more folks. And we are about at time. Anybody else? Any last?
There was one other question about what age group it would be approved. So it is under, we just want to make it very clear, it's still under investigational drug use, and we are doing that under that IND possibility. The reason why it was because of exclusivity initially, because another company had a 30-day preparation, and so the FDA did not approve it. They were about to approve it, and there were some issues with the production line in a factory, so they kept it off for a few months. We have some information. It may come to, it might come to be used and FDA approved in the middle of this year, but we really don't have any positive exact amount, what the age group will be or when that will happen. We just want to get this out there so that if it does happen to be next week or next month, that you will understand what the product is and what our experiences have been. But we would anticipate it that sometime this year, the drug will be FDA approved medication.
All right, and with that, I guess we can close out the section. We're all certainly available for questions online. Our emails are very easy to find either through the Juno platform or our websites. We thank you for being with us here today. And treat opioid use disorder.
Thank you, everybody.
Thank you.
Bye. Thanks.
Bye.